For the late-stage patient or for the neoadjuvant patient, we have to do the genotyping to select the optimal drugs. But we all know that gene mutation assessment is very slow. It takes 1 to 2 weeks. So we're trying to find another way, another solution for this. So we established a pathological AI model which can predict the gene mutation status, so it can provide an enrichment pathway for us to predict the mutation.
The International Society of Oncology Prevention and Treatment, or ISOPT, believes every adult deserves to know their cancer risk before cancer arrives.
Here, I would like to present a little bit about some of my perspectives about the multidisciplinary management of lung cancer. We always said the optimal treatment for lung cancer is comprehensive treatment. So we combine all the treatment modality like surgery, chemotherapy, immunotherapy, and targeted therapy, radiotherapy together. So we would like to have an optimal combination of all this therapy to achieve the best efficacy in treating the lung cancer. So our hospital is focused on the respiratory medicine, especially in China, and we have a great burden of huge volume of lung cancer cases, and we established multiple center cohorts and the biobank. Then we focus on the precise early management of the lung cancer, including the screening, diagnosis, resection, and recurrence prediction, etc. So first of all, I would like to share some data from a national inpatient lung cancer registry in China, which include about 7 million lung cancer inpatient cases from 2016 to 2021. In this database analysis, we identify the treatment pattern, the trends of the treatment pattern in the lung cancer. So we could see the patients who take the treatment increase over the last decade, and especially the new adjuvant therapy. We could see here, although the proportion of new adjuvant therapy is still very low, just about 1%, but we could see the increased trend of the neoadjuvant and adjuvant therapy. And we could see these trends, the increase in the high developed area is more significant than those than other regions. So we could see the comprehensive treatment now in China is increasing. Then there are some points we have special attention. For example, the stage 1A non-small cell lung cancer, which were considered can with the adjuvant therapy in the past, because the chemotherapy did not add additional benefit in this population. But in this population, we still see some recurrence. So the key point is how to identify the recurrence patient at risk accurately and give them the effective therapy outside the low effective chemotherapy. Previously, we established a 14-gene assay to accurately predict the post-operative recurrence, which was available in the US and also in China right now. So by using this assay, first of all, we have a retrospective cohort showing that patients in stage 1A who take the adjuvant EGFR TKI don't show any recurrence. Comparatively, we could see patients who under only surveillance, we could see about 20% of recurrence. And after enrichment by the 14-gene assay, we could see the high risk defined by the 14-gene assay have the 30% of recurrence after surgery in stage 1 patients. But after using the adjuvant EGFR TKI, we could see the recurrence is less than 5%. So that provides evidence the high-risk stage 1A patients should have the adjuvant therapy. According a forward study, which is a registry study to study the adjuvant furmonertinib a third generation TKI developed by Chinese industry. In this study, we first time to include the stage 1A patients with high risk factors, not only stage 1B, but beyond, but expanded to the stage 1A patients. Then, by our center, we also performing multi-center study, focus only on the stage 1A to 1B patients with the high risk factors defined by the clinical high risk factors and the 40 gene assay panel. So in this prospective study, we could see we deliver the targeted therapy for the EAR patients and for the and the PD-1 for the white type patients. Another issue about the candidate for adjuvant therapy is the multiple primary lung cancer, which represents about 15% of early stage lung cancer cases in China, also in the East Asia. So for these multiple lesions, after the surgery, patients will be very anxious about the growth of the or the progression of the lesions. So it's also can also be considered a candidate for adjuvant therapy. We established a model to predict the gene mutation of the multiple lesions because we could not take biopsy for all the lesions. So we used the radiomic AI to identify the EGFR mutation status. Those with multiple primary lung cancer, which consider to have the EGFR mutation. So we could see a typical cases here. The multiple lesions experience complete response after the EGFR treatment. So the overall response rate is about 60%, and the outcome is we will prevent some of the resurgery of these patients. So many of the patients who take the EGFR TKI, they will not have the multiple surgery after the initial one. And another issue about the adjuvant therapy is the chemotherapy should be maintained after it provided we have used the EGFR TKI. First of all, we could see some retrospective evidence that the EGFR mutated patient have no benefit from the chemotherapy because it's a very low immunogenicity tumor. So according to the ABDORA study, we have performed a reanalysis of the survival curve. We could see here for all stage patients, the chemotherapy before the EGFR TKI did not show any additional benefit. So that means if we use the EGFR TKI, maybe we could waive the chemotherapy. Instead, we should prolong the use of the EGFR TKI because 2 to 3 years of use of the EGFR TKI, we could see all warning effects of these patients. Most patients will experience recurrence after the withdrawal of the drugs. So we have to prolong the treatment of the EGFR TKI of the all TKIs. For the neoadjuvant IO therapy, we focus on the optimal cycles for treatment because we in our previous randomized control trial or clinical trials, 2 to 6 cycles will be varies from 2 to 6 cycles. According to a real-world study, we identified 3 to 4 cycles is optimal. But now when we expanded to the multi-center study, maybe over 4 cycles would be recommended. And we should not forget the surgery, the role of the surgery in the neoadjuvant population. We have a real-world study showing that for the stage 3 patients, if the patients choose the surgery over the radiotherapy, we could see the better overall survival when they use the surgery. So I think the surgery also play a important role in those who were considered unresectable initially. We also identify a very interesting phenomenon that the lymph node positive patients, that means mostly stage 2 to 3 patients, will have only 1/8 of the MPR rates compared to lymph node negative patients. So the mechanism underlying this phenomenon might be the metastatic lymph node will not mature and show less TLS in the primary lesions. So for such population with the positive lymph nodes, we should have some enhanced therapy, but we are trying to find some way to increase the MPR rate of these patients. Previously, for the pathological response assessment, we maybe only focus on the primary lesion, but the lymph node, we should also assess the MPR rate. So according to some algorithm, we confirm that the MPR definition for lymph node is also less than is also a cutoff less than 10 live cells, 10% of live cells in the lesion. We could see very clearly different MPR status between the primary and lymph nodes. About 40% they disagree with each other. And then we also show some evidence that if we combine the MPR rates of the primary tumor and the lymph node together, we could have a better prediction of the prognosis. So that means we should assess the lymph node also in terms of the pathological response. For the late stage patient or for the neoadjuvant patient, we have to do the genotyping to select the optimal drugs. But we all know that gene mutation assessment is very slow. It takes 1 to 2 weeks and maybe maybe a little bit expensive for most of the Chinese population. Maybe in the cities it's okay, but in the rural, in the undeveloped area, the gene mutation assessment is not available. So we're trying to find another way, another solution for this. So we established a pathological AI model which can predict the gene mutation status. So it can provide an enrichment pathway for us to predict the mutation and then deliver the very simple validation method like the PCR or IHC. Now we are performing a randomized control trial to see those in the undeveloped area who will not take gene mutation test, who will never take the gene mutation test. We will randomize the patient. We use the pathological AI to predict if we have the positive result for the gene mutation prediction. We will suggest the patient to take the PCR or IHC for EGFR and for ALK-ROS1 respectively. So we could see if we could increase the drug use rates of the targeted therapy and also the overall survival. And last, for the late stage patients, we will never forget the local treatment like the surgery and the radiotherapy. So we also perform a study to see if we use the en bloc biopsy for the primary lesion of the patients. Previously, we would routinely use the needle biopsy for the late stage patients. But if some lesions can be resectable, so we would use the surgery to do the biopsy. By using the surgery biopsy, we could see the successful rate of the NGS testing is 100% because we have a good volume of the tumor sample. But for the needle biopsy, about 40% of the patients cannot have the sufficient sample to be for the gene testing. So that means if we use the needle biopsy, some of the patients will lose the chance to take the adjuvant to take the targeted therapy. We could see here if the patient can take targeted therapy, it would definitely increase the survival. And so here we could see the en bloc biopsy measure outperform the needle biopsy in the late stage patients. So I think the surgery can have a good role in the treatment and as a comprehensive method for the late stage patients. So that's some of my points. Thank you very much.
Thank you very much, Dr. Liang, and thanks to everyone for very good input to the multidisciplinary discussion. I think we have run out of time, so we could continue for hours, but that will be next time. Thank you very much, everyone.